So there's two different approaches to exercise referral schemes. In the first approach, it's a healthcare professional, a primary care physician or a secondary care physician who has a discussion with a patient about their physical activity levels and identifies that they need to increase their physical activity, and then actually talks to them and prescribes an amount of exercise to do and gives them a written prescription. The evidence base for this is there's only been one systematic review done, and it's that it probably increases physical activity. The problem is that people adapt the intervention to do it in different ways, so it should just be about giving advice and then encouraging people to make their own decisions. But some people have added in pedometers or bike usage to that, so it's really difficult to know what elements of the intervention work properly. So I think the jury's out. It does help to increase physical activity, but we don't know how. The second approach is where a healthcare professional refers people to some sort of physical activity organisation, like a leisure centre, and then they help to people to take part in supervised exercise. And the evidence base for that is that it does increase physical activity in the short term for older people and for people who have coronary heart disease risk factors. So same problem in that everybody's doing slightly different things, so we don't really know what works. We know that older people are more likely to be referred, which is not surprising because they're the people that have the medical conditions that are trying to be targeted. And we know that older people are more likely to engage as well, so those who are over 55 are more likely to engage. They're more likely to be referred, they're more likely to be engaged, and they're more likely to stay and actually adhere and become more physically active. Those who are referred for coronary heart disease risk factors are also more likely to engage than people who are referred for, say, mental health problems. Women are more likely to be referred into schemes, but are not more likely to engage, and they're not more likely to adhere than men. So if you can engage with the men, then it makes no difference, but they don't get referred in the first place. One of the main problems is that there are a lot of existing schemes that are not based on a strong evidence-based approach. So everyone's choosing to do the same principle but in different ways. So they have different scheme lengths, they offer different types of physical activity, they ask people to come in a different number of times a week, and they use different behaviour change methods to try and encourage people. So some schemes are very focused on goal setting and getting people to choose what they're doing. Other schemes just say, come in and we'll tell you what to do. So we don't really know what works, and it's hard to go back to a randomised control approach. Firstly, because we don't know what works, so we don't really know what to pilot, and secondly, because those schemes exist, there's so many of them that actually it's really difficult to do an RCT anyway. So what we need to do is look at how we can evaluate the existing schemes to try and make sure that they do have an effect. And so the problem with that is that everyone's not only doing different things, but they're also collecting evidence about what works in a different way. So what we need to do is we need to have a way in which people can describe their schemes so that there's a record of exactly what people are doing. And then the other thing we do is we need to have a data set that everybody collects. So if the primary outcome is to increase physical activity, we need everybody to collect the data about whether they're increasing physical activity in the same way. So if these are being done by non-academic organisations, it might be reasonable that they're using a validated self-report questionnaire for physical activity, but everybody's using the same one, so then we can compare across the schemes and try and understand what works. So there's been very little done in terms of digital health technologies, but there's definitely a huge amount of potential to use apps, I think, to support, we have a lot of wearable technology now. the older population is definitely a lot more digitally literate than they used to be. So I think using wearable technology to try and encourage, because people come to these schemes, but we're trying to encourage people to do 150 minutes of exercise every week, but they may only come to the scheme once or twice a week, and maybe that's for an hour. So even if they exercise for the whole hour that they were there, they're still not achieving the 150 minutes a week. So if we can encourage them to use digital technology like an app or a watch that counts your steps, or even your phone that counts your steps, then you can encourage people to actually do extra outside and to be able to monitor what they're doing. And the other thing is, for people who live in rural communities who maybe don't want to go to a centre, then you can use that digital technology to track and also to talk to them and send them messages about what they're doing.